Good morning, everyone. My name is Shivam Ranagoti, and my moderator is Dr. Abhijit. Today, I'll be presenting on the topic release reflexes. Release reflexes, primitive, fetal, developmental, or atavistic reflexes, are a group of behavioral motor responses originating in the central nervous system and exhibited by normal infants but not in neurologically intact adults in response to particular stimuli. These reflexes are normally kept in check by the frontal lobe, may indicate a diffuse CNS disease when present, can be present normally during senescence. Many are exaggeration of normal response. Adaptive value of reflexes. Many of these reflexes have got adaptive and survival value during development of an infancy. For example, sucking and rooting reflex helps in feeding, grasp reflex helps in bonding. Almost all disappears as the child develops. Some may persist in adult as normal variant. An exaggerated response is seen in abnormal neurology. They are seen in severe dementias, diffuse encephalopathy, head injury, stroke, cerebral palsy, or autism spectrum disorders. They are particularly seen in disease or damage of the frontal areas and therefore also called frontal release reflexes. Common release reflexes are palmomental reflex, grasp reflex, which can be both palmar and plantar, the glandular tap reflex, mucocephalic reflex, and the arm dropping test. The palmomental reflex. There is contraction of the mentalis and orbicularis oris muscles, causing wrinkling of the skin of the chin with slight retraction in response to scratching or stroking the palm of the ipsilateral hand. Method: stroking a blunt point over the thenar eminence or by tapping this area. Response can be present in ipsilateral or contralateral lesions. Can be seen in normal people also. Helpful in facial palsy. Absent in novel motor neuron type and exaggerated in upper motor neuron type. The palmar grasp reflex. Involuntary flexor response of the fingers and hand following stimulation of the skin of the palmar surface of the fingers or hand. Normally seen at birth, disappears by 2 to 4 months. Seen in extensive frontal lobe lesions, for example, neoplastic, vascular, and degenerative lesions. Also seen in corticospinal tract lesions. When present, unilaterally indicates lesion of contralateral frontal or parietal lobe lesion. The plantar grasp reflex seen in disease of the opposite frontal lobe elicit elicited by drawing the handle of a reflex hammer from the midsole towards the toes flex in response. The glandular tap reflex. Tapping over outer aspect of the supraorbital ridge over glabella or orbital margin produces bilateral eye blinking. Appears at 32 weeks, disappears around 3 to 4 months. It is uninhibited in diseases like Parkinson's disease or a frontal lobe damage. This sign is also called Myerson sign. Note, the glandular tap reflex is neither sensitive for the presence of intracerebral pathology nor specific for Parkinsonism. The mucocephalic reflex. It is elicited by rapidly turning the shoulders of a standing patient to the left or right, to the right or left. Head holds its active original position, seen in diffuse cerebral dysfunction. The arm dropping test. Patient is asked to completely relax, suddenly release elevated arms of the patient. Failure to let the arm drop freely is seen in frontal lobe diseases. These are my references. Thank you. References. Strategies. Examination. Medicine college examination.
Good morning, everyone. I'm Shinjini, and my topic for today is psychopathology. And my moderator is Dr. Abhishri Ranjana. What is psychopathology? Psychopathology is a systemic study of abnormal experience, cognition, and behavior, the study of the products of a disordered mind. It includes explanatory psychopathologies and descriptive psychopathology. Explanatory psychopathology. It includes the assumed explanations according to theoretical constructs, for example, on a cognitive, behavioral, psychodynamic, or essential basis, and so on. Explanatory psychopathologies, in contrast, often assume that mental phenomena are meaningful. In psychoanalysis, for example, at least one of the several basic mechanisms are assumed to be taking place, and the mental state becomes understandable. Explanations of what occurs in thought or behavior are based on these underlying theoretical processes, such as transference or ego defense mechanism. Descriptive psychopathology. Descriptive psychopathology is a precise description, categorization, and definition of abnormal experiences as recounted by the patient and observed in his behavior. It is distinct from other forms of psychopathology as it avoids explanation of the phenomena that it describes. It simply describes, thereby avoiding arguments about causation. Hence, descriptive psychopathology guards against and avoids theory, presupposition, and prejudice. Descriptive versus explanatory psychopathology. Descriptive psychopathology is empathetic evaluation of patients' subjective experiences. It is description of a phenomena, understanding the patient's subjective state through empathetic interview. It makes distinctions between understanding and explanation. Understanding through observation and empathy. Form and content are clearly separated. Form of importance for diagnosis and process and developmental distinguish. Interferes with developmental basis. Whereas psychoanalytic or explanatory psychopathology study the roots of current behavior and conscious experiences through unconscious conflicts. Theoretical processes are demonstrated, free associations, dreams, and transference. Understanding in terms of notional theoretical processes. No distinction made and concerned with content. Symptoms are seen as having unconscious psychological basis. Phenomenology versus psychopathology. Psychopathology is concerned with abnormal experience, cognition, and behavior. Descriptive psychopathology avoids theoretical explanations for any psychological events. It describes and categorizes the abnormal experience as recounted by the patient and observed in his behavior. Whereas phenomenology is usually used to denote inquiry into one's conscious and intellectual process. It involves the elicitation and description of abnormal psychological events, the internal experiences of the patient, and his consequent behavior. An attempt is made to listen attentively, accurately observe, and understand the psychological event or phenomena so that the observer can, as far as possible, know for oneself what the patient experience must feel like. Concepts of psychopathology, disease, and illness. Psychopathology concerns itself with the disease of the mind, and in most psychiatric disease, no typical morbid anatomy or pathophysiology has been described. A simple dictum is to regard disease as what doctors treat, and illness is what as the person suffers from. Norms, normal, and abnormal. The subject of psychiatry is the person, not an organ such as liver, kidney, or even the brain. Psychiatric diseases are distinct from mere neurological diseases in the sense that in psychiatry, the disease afflict the self, that is, affect the person in deep and not in superficial sense. Understanding and ununderstandable. Understanding cannot be complete unless the doctor has a detailed knowledge of the patient's background culture and specific information about his family and immediate environment. Understanding and explanation are both necessary parts of psychiatric investigation. Explanation is concerned with accounting for events from a point of observation outside them, and understanding is from inside them. Empathy. The method of empathy implies using the ability to feel oneself into the situation of the other person by proceeding through an organized series of questions, rephrasing and reiterating until one is quite sure of what is being described by the patient. Form and content. The form is dependent on and is therefore a diagnostic key to the particular mental illness from which the patient suffers. The content can be understood by patient's life situation with regard to culture, peer group status, age, sex, life events, etc. Primary and secondary phenomenon. Primary is immediate and ultimate, and therefore cannot be reduced by understanding or example hallucination. Secondary is what emerges from the primary in a way that can be understood. For example, delusion arising from healthy parts of sight in response to hallucinations. Subjectivity and objectivity in psychopathology. Objective assessments in psychiatry can be many physiological measures, the measurement of body movements, facial expressions, patient's writing, learning capacity, memory span, and work efficiency. All of these can be quantified and analyzed objectively. Subjective analysis can be made, for example, from the facial expression or from the patient's description of himself, of his own writing or inner events. Unconscious experience and phenomenology. Phenomenology cannot be concerned with the unconscious because the patient cannot describe it, so the doctor cannot emphasize. Organic and neural substrate and psychopathology. Psychopathology is the study of mental process, so that even when the organic causes of the conditions are known, psychopathology remains involved in describing, defining, and ordering the symptomatic phenomena. Mind-brain duality and psychopathology. Cartesian dualism is the view that mind and body are separate substances. The mind happens to be associated with the particular body, but is ultimately self-sufficient and capable of independent existence. Uh, this is my resource. Thank you.
Good morning, everyone. I am Shivam and I am going to present on the topic sports and psychiatry. And my moderator is Dr. Vijay. Definition: sports psychiatry is a medical specialty that aims to treat and prevent mental disorders in athletes and helps them to use different techniques to enhance their performance. First mentioned in literature in 1967, it is a developing area that relies on other fields like sports psychology. History. The first publication on sports psychiatry was written in 1967 by Arnold R. Weiser, a doctor and tennis player. It was brought up in literature again 20 years later by J.H. Rick Massimino, MD, and mentioned again in 1992 by California-based psychiatrist Daniel Beagle, who is known for officially launching the specialty. As the field developed, the World Psychiatric Association eventually created a section on exercise and sports psychiatry, giving way for interest in other countries, including Britain and Germany. Governing bodies. Various societies have been formed in the field of sports psychiatry. Some of them are International Society for Sports Psychiatry, American Board of Sports and Performance Psychiatry, International Society for Sports Psychiatry. In 1994, Beagle founded the International Society for Sports Psychiatry. The organization aims to spread the benefits of the field to entire athletic community and promote mental health in sports. ISSP membership in 2020 is open to medical students, residents, psychiatrists, and other clinicians at times. American Board of Sports and Performance Psychiatry. In 2023, 7 sports psychiatrists founded the American Board of Sports and Performance Psychiatry. Their mission is to credential sports and performance psychiatrists who demonstrate excellence in the comprehensive care of athletes and performers, fostering mental well-being and optimal performance. ABSPP aims to enhance the mental health and well-being of athletes, performers, executives, and individuals striving for peak performance in their personal and professional lives. Common areas of study. Some of the most commonly found mental disorders in athletes that sports psychiatrists may come in contact with include mood disorders, such as major depressive disorder, bipolar disorder, anxiety disorders, including social anxiety disorder, obsessive compulsive disorder, eating disorders, attention deficit hyperactivity disorder, and substance abuse. And more sports-specific ones are concussions, body dysmorphic disorder, traumatic brain injuries, and chronic traumatic encephalopathy. Eating and body dysmorphic disorders have higher incidence in women. In sports that emphasize appearance, like gymnastics or figure skating, substance abuse is commonly found in athletic community. College athletes have been reported to use alcohol at higher levels than the general public despite its detriment to performance. Anabolic steroids are also a widely abused substance among athletes. These aid athletes in faster training and recovery time, but may also have psychiatric side effects like irritability and mood swings. Substance abuse is a concern among elite athletes. Treatments offered. Commonly used techniques: The treatment of choice for many mental illnesses experienced by athletes include psychotropic medication as well as, depending on the specific situation and life of the athlete, psychotherapy, psychoeducation, counseling, and family therapy. Psychotropic medication. Usually, sports psychiatrists choose non-sedating medications because they are less likely to cause side effects, such as an increase in weight and body weight, body fat, sedentary behavior, a decrease in insulin sensitivity, and cardiac issues. The effect on athletes' performance must also be taken into consideration, as well as the anti-doping guidelines of these different sport leagues. The World Anti-Doping Agency provides a list of generally banned substances, and it is left to each league's discretion to add a more strict code. Widely used medications include antidepressants, example, bupropion, mood stabilizers, anticonvulsants, and anxiolytics, psychostimulants, ADHD medications, and sometimes sedative hypnotics and antipsychotics. Mental health stigma. In professional sports, more than the others, seeking assistance to improve one's mental health is often stigmatized. Athletes will most commonly seek help from psychologists first or not go to help at all, and serious mental health related issues might go unrecognized. Hence, another role for sports psychiatrists is to help destigmatize and promote mental health among athletes. So these are my references.
Specialized subject. देखा कोई what is upper motor neuron and what is lower motor neuron? होता है होता है और lower motor और के नीचे कहीं तो ऊपर डिस्कस कर ब्रेन के देखिए तो मौसम मॉडल और एंडियर मॉडल से एनर्जी रिडक्शन मसल्स because it's now because बोला ना अपन मोटर न्यूरॉन बताया हैंडल रिलीज इफेक्ट्स है साइकोपैथोलॉजी बोलते हैं हम क्या 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 होता है साइकोपैथोलॉजी बहुत पुराना काम है कि एक्सप्लेन करते हैं बहुत से नाम है किसी बहुत के बिहेवियर में तो बायोलॉजिकल की तरफ ज़्यादा जाते हैं साइकोलॉजी साइकियाट्री स्टिल इन फ्लक्स पुराना जो था ईगो सुपरईगो okay so these were used to describe your hyper you know last and strong जैसे फिजिक्स में लॉज ऑफ न्यूटन पढ़ते हैं तो लॉज ऑफ फिजिक्स भी वो अप्लाई करते हैं बट व्हेन यू गो फॉर क्वांटम एंड इफ यू गो फॉर स्पेस देन दीस लॉज फेल ठीक नो क्वेश्चन you did all three you did basically the two towns we get for a short people and ready. हमारे डेजिग्नेट लिस्टर है अभी अगर उसे पढ़ के एमसीक्यू सॉल्व कर लोगे सब्जेक्ट नहीं पढ़ना टेक्स्ट बुक पढ़ने के टेक्स्ट बुक पढ़ोगे तो कॉन्सेप्ट समझ में आएगा तो कम से कम 70% तो तुम वैसे ही सॉल्व करो focus on MCQ is detrimental to the education of medical science. क्या है कि लोगों के लिए इंटर्न for doing night duty or they are off for illness and each they are of the unit. Okay, they are field allocation. You have to do that day. That will be the evening duty है तो you will have to inform the senior resident there is okay. To perform those duties, you can just log whatever duties there is. Is it signed by the designated yeah, and then you can have a next. So, and if you want to learn, please stick with us, come to OPT, talk to us, talk to the consultant, and we'll also be giving class to a junior resident to teach you some things. So you can also mental state examination, you should know. Uses of basic medical chemicals, you should know. And some basic medication जैसे एक्सपोजर होता है शुड डिस्चार्ज जैसे बनाते हो और डोज लिखते हो तो पूछो कि ये सॉल्ट कौन सा है ठीक so you stick to the junior level learn not only the clinical stuff but learn clinical जैसे ओपीडी में याद junior allocate patients to the and present the case along with the interns to the okay please in my OPD right and JR can present or the intern can present so you should know how the patient most of the patients present in OPD so actually the crux of psychiatry in OPD in wards we see few patients and they are usually similar type of patients to the same type of so but the variety is very when you are posted in OPD try to see the patients try to focusing references with learn consultation guidance okay. Not just write down but also learn the